Hello, I'm Michael B. Sisti. I'm talking to you from my office at the Neurological Institute of New York at Columbia University Irving Medical Center, New York Presbyterian Hospital. I'm going to talk to you about a topic today concerning the treatment of brain tumors, where we have our greatest challenges and our greatest triumphs. The first thing I'd like to talk about, the cancer diagnosis of the brain, are the ones that are most easy for us to deal with and treat, and then I'm going to talk about tumors that arise from the brain directly. The class of tumors that involve the brain that are easier for us to treat are tumors that originate elsewhere in the body and go to the brain. What I'm talking about is if you had a diagnosis of breast cancer, lung cancer, or colon cancer, sometimes these cancer cells can gain access to the bloodstream. And unfortunately, occasionally these tumor cells can enter through your lungs, up through your heart, into your brain, and set up resonance in there. They may or may not grow. But the ones that do grow within the brain that have come from a different organ in your body, we call those metastases. And the most common ones by far are from breast cancer, lung cancer, or colon cancer. They can occur anywhere within the brain, but generally they occur in the upper part of the brain as opposed to the lower part. Very common symptoms are things that look like strokes, actually. A person may be fine 1 minute and then a very short period of time may develop headaches, weakness, difficulty with speech, movement, or memory. There's generally a very dramatic change in neurologic function over a short period of time because a tumor cell that doesn't belong in the brain, like a breast cancer cell or a lung cancer cell, creates a tremendous inflammatory response within the brain, even in tumors that are quite small. So patients who have a history of cancer, and if they develop neurological problems, almost always their medical doctor or their oncologist will order an MRI scan of the brain. The MRI scan may show a lesion in the brain. It's usually close to the surface because that's where the tiny little blood vessels trap the tumor cells. And around that tumor could be a very, very large area of brain swelling. Almost always before a patient gets to me, your medical doctor or your oncologist will have placed you on an anti-swelling medication called Decadron, which is a steroid, dexamethasone, potentially even an anti-seizure medication. By the time patients come to my office, generally within a day or so, there's been a significant improvement in neurologic function because most of the symptoms patients have from cancers that originate elsewhere in the body that go to the brain are the brain's inflammatory reaction to that. So in patients who have already had an experience with the medical system and their doctors, this is of course a terrifying kind of event, but the good thing about this is that early diagnosis and early intervention very frequently gets patients the best possible outcome. For instance, if you have a very small tumor and it's in a very strategic location in which surgery could be risky, we could readily treat that and frequently do on an outpatient basis using gamma knife radiosurgery. Gamma knife has been a godsend for my patients with metastatic cancer to the brain because these treatments can be done on an outpatient basis, highly effective at controlling the tumor at exactly where it's located, and can be given in multiple locations. For instance, if you had multiple small lesions in the brain, 5, 6, 10, 15, 20, all of these sometimes can be treated in a single treatment session, which in this correctly selected patient has significant advantages over radiating your entire brain. And so we've used this technology to control the tumors locally, to prevent damage to the brain from unnecessary radiation, and perhaps more importantly, because the brain is only one part of a patient's experience if they're dealing with systemic cancer, is that this radiosurgery, because it's outpatient, completely non-invasive, doesn't interfere with the other necessary treatments you need, such as chemotherapy or radiation therapy for some place in your body. So if we can possibly treat your metastases without surgery, we're certainly going to do that, and that usually happens, at least in the kind of patients I'm seeing, maybe in 2/3 of the patients that come to see me initially. You may not need an operation. We may be able, with our experience here, which is very deep. We've been doing radiosurgery here since 1989. We currently use the Icon Gamma Knife platform, which works on these moldable plastic masks, which I like making for my patients. And there's no invasion of this. There's essentially no hair loss. It doesn't interfere with your necessary chemotherapy or other treatments. And in fact, that's almost always an advantage to have those treatments while you're getting radiosurgery. And literally, you can leave the unit right after the treatment and resume your life or go to other treatments that you need. So the treatment of metastatic tumors, when it deals with small tumors, even multiple ones, We much prefer to treat them non-surgically on an outpatient basis with Gamma Knife because local control is excellent, doesn't interfere with your treatments, and your treatments actually are synergistic with the radiosurgery. It may give us a better result. And we can do it as many times as we need to, so it's always there for you. Occasionally, however, if somebody comes in with a very large tumor, it may be one large one or one large one and a couple of small ones. If it's a large one, we have, and it's just one, we have a special name for that. We call that a solitary metastasis. And a solitary metastasis almost always, if it's close to the surface of the brain, and let's say more than an inch or 2 inches in size, is something we're going to want to surgically excise. Fortunately, these tumors generally come very close to the brain, and shockingly, on many times, if you're in good condition and otherwise healthy, occasionally these surgeries can be done with intravenous anesthesia. You know, I know that sounds a little scary, but if you get anesthesia through an IV like you would for a colonoscopy or a major dental procedure, you don't remember anything, you don't feel anything, and this has huge advantages for a patient who's being treated with systemic cancer, because we're not going to subject you, if we can possibly do it, with general anesthesia and using it with conscious sedation, intravenous anesthesia, like a colonoscopy technique, will get you out of the hospital much faster than you ordinarily would, and doesn't interfere with the other necessary treatments that your doctors, your oncologists are using to try and control your local tumor. So I like these kinds of minimally invasive, conscious sedation, guided by computer. I never shave any hair in my neurosurgery procedures, so generally most patients won't have any marks left from this. But it would be unrealistic to assume that even a perfect surgical result on an MRI scan showing that the tumor is out, can't find it on your postoperative MRI scan, and you look really good. In fact, generally you get better right away, because if you have a large tumor that's symptomatic and you remove it, the symptoms have a tendency to get better very quickly. So if that's the case, one of the things we like to do in conjunction with radiation oncology and medical oncology is again to go back to the Gamma Knife technology, and sometimes in the hospital stay or sometimes shortly thereafter, what we could do is boost the cavity of the surgical resection with a single outpatient dose of radiosurgery. This is like surgery plus, I call it, because you don't really, in surgery, want to go beyond the edge of the metastases. The metastases, when it grows in the brain, pushes the brain cells out of the way. So you want to stay very close in surgery between the edge of your tumor and the edge of your brain. But when you stay that close, it's possible that there could be microscopic invisible cancer cells even on a normal MRI scan. And so when you've healed sufficiently from the surgery, anywhere within the first week to the first month, sometimes when you're coming back to have your staples out or see another doctor, we'll give an additional boost of radiation right to the edge of where the surgery was to suppress a local recurrence while you're getting other necessary treatments. So metastatic cancer, lung, breast, colon are the three large ones we treat here. The advent of microsurgery, of radiosurgery has really changed the game in the 21st century. In my experience from working in the 20th century when we didn't have this kind of technology, in converting things that were once untreatable, particularly deeply situated metastatic tumors in critical brain areas, to a highly controllable situation that doesn't interfere with your necessary treatments and which can be used as often as we think is appropriate based upon how you're doing and what your radiation oncologist and what your medical oncologist want to do. And so obviously the team of doctors here, which also includes some very important oncology nurses, usually meets at a periodic basis once every week to discuss the management of metastatic patients who have metastatic cancer to the brain, about what's the best way in each individual patient's situation to manage that metastases. We generally will defer to the medical oncologist if they feel that other critical medical treatments are necessary prior to surgery. But if surgery is the right thing for you, as opposed to radiosurgery, we usually like to get that done as soon as possible. So I generally see patients in my New York office on Monday afternoons and Thursdays. Usually that week or the next week, we're going to do your surgery, because the sooner we can get to your metastases, the better you're going to get and the faster you can get on to other necessary treatments, including the Gamma Knife radiosurgery one. So I know it's a complicated topic because it's so variable. There's no location that's safe in the brain from a metastatic tumor, but then again, there's no location we can't reach in some circumstances with surgery and in other circumstances with radiosurgery. and sometimes we need a little bit of both. And I think that's a huge advantage. If you do surgery and radiosurgery, you know how to use these two very powerful ways of controlling cancer in the brain with either surgery or radiosurgery, so they're not in conflict with one another, to avoid the long-term side effects of whole brain radiation therapy, particularly if you're receiving concomitant chemotherapy. So it's a challenge, but it's a solvable challenge. We've helped patients tremendously in the past 20 years using these advanced radiation and surgical techniques to get the best possible result we can expect from what is a very difficult problem that involves your entire body. I know this is a difficult topic. I hope I've answered some of your questions, and I think it's realistic in many circumstances to say that of all the things in the cancer world that we've made a huge advance in terms of giving the best possible result and a good quality of life and minimal complications that interfere with your other necessary life-saving treatments. I think the interplay of advanced computer-guided microneurosurgery and icon gamma knife radiosurgery has really done a world of good for my patients with metastatic cancer to the brain. And if you need this help, myself, the excellent doctors that I work with in radiation oncology, medical oncology, and nursing, the resources of this amazing university, we're all here on your side to help you to get the best possible result. Thank you.